The way that we'll teach our new nurses is think about what organs lie in the radiation field. And anything that lies in that radiation field is likely going to have some potential temporary, hopefully temporary side effects. If you think about the pelvis, the things that live in there are, bladder, urethra, some bowel, rectum, reproductive organs, skin, some lymph nodes. And so all of those things could potentially have associated side effects.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between.
Hello, and welcome to the ONS podcast. I'm your host, Lenise Taylor, Oncology Clinical Specialist at ONS, and today we're talking with Kayla Kafka-Peterson, Nurse Navigator and Leader in the Brachytherapy and peri-anesthesia programs at UCLA Health in Los Angeles, California, about radiation side effects in cancers of the pelvis. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the notes. Thanks for joining us today, Kayla.
Yes, thank you for having me.
Let's start with what types of pelvic cancers are commonly treated with radiation and what radiation techniques are commonly used.
We can actually treat a lot of different types of pelvic cancer with radiation. Most commonly, we will see cervical cancer, endometrial, vaginal, vulvar, prostate cancer, bladder cancer, even at times urethral, rectal, anal, sarcoma, bone, recurrent cancers. We really can use it for a lot of different types of treatments. And there's a lot of different techniques that are used. Most commonly, external beam radiation therapy is what comes to mind for most, such as IMRT or SBRT. There's many types of external beam treatment, as well as brachytherapy, which is available in a few different forms as well.
You mentioned brachytherapy and how it's often used with pelvic cancers like cervical and prostate cancers. Can you give us the overview of the science behind it and how it's administered?
So brachytherapy is a less common known type of radiation, but it is definitely growing in its use around the world. And it's actually been around for a very long time. It's been around for almost 100 years. It is commonly used in the setting of cervical cancer, as well as other types of cancer like prostate, rectal, etc. And most of the time, this type of treatment is given internally instead of externally, like external beam. And I say most of the time because you can also give brachytherapy topically on the skin, but the majority of the time it is delivered internally into the tissues, such as an interstitial approach, or into an existing body cavity like the vagina and an intracavitary approach. You basically go directly to the area that you want to treat. And this can be delivered a few different ways, LDR brachytherapy and HDR brachytherapy, but you will bring the radiation directly to the area you want to treat, and you can spare the surrounding tissues. So you can give a very powerful dose directly where you want it while sparing everything around it to help with side effect control. Brachytherapy is delivered two main ways. The most common is LDR and HDR. LDR stands for low dose rate radiation, which is the older type of brachytherapy, but it is still very much practiced today. And it is where we put radioactive seeds directly into the tumor or tumor resection bed, depending on what you're treating. And those pieces of radioactive material, such as iodine 125 or palladium 103, those will give off radiation over time and treat the area that they are in. And they will place more or less seeds into the tumor depending on that patient's needs and their anatomy. That's LDR brachytherapy. Radioactive seeds are placed in, they stay in, they give off radiation over time until eventually all of the radiation is gone. And then they're just these inactive seeds that remain in the body cavity. It's very common for prostate. For HDR brachytherapy, the science is a little bit different. It's called HDR high dose rate brachytherapy, which is the newer version of brachytherapy that a lot of centers are practicing, where we temporarily will deliver radiation through an existing applicator or through these special hollow needles. They can be made out of metal, they can be made out of plastic, and you can access different areas of the body. And then those applicators or needles are attached to these tubes called transfer tubes, which attach to a machine called an afterloader, a remote afterloader, which houses a piece of radioactive material such as iridium-192. And it will temporarily send radiation through via this machine through each one of these tubes into the area to be treated, dwelling more or less at various points along the pathway to give more or less radiation depending on that patient's needs. And once the treatment is complete, the source goes back into the afterloader and all radiation is gone at that point. So that has delivered the high dose rate brachytherapy that way. So that's the brachytherapy science in a nutshell. Very targeted, usually internal, and a very, very powerful dose because you're going directly to the source.
So, how is radiation used in combination with other treatment modalities?
It depends on the type of cancer that we are treating. I think a good example is cervical cancer, where radiation is part of an overall treatment plan. For locally advanced cervical cancer, it's very common to give chemotherapy plus external beam radiation plus brachytherapy at the end as a boost. And now they're also adding immunotherapy in for a lot of these patients. It works together with the chemotherapy in this case because the radiation will work to damage the DNA itself. The chemotherapy helps make those cancer cells sensitized and therefore easier to kill, and can also help treat hidden disease or any systemic disease. And together they produce a stronger combined anti-cancer effect because they are working together. And then at the end, we get a brachytherapy boost, very commonly used in locally advanced cervix, as a really powerful end dose to really try to dose the direct area needing treatment. That's an example of how you can use radiation, but it can be used in combination with surgery. It can be used by itself. It can be used before surgery, after surgery. There's many indications for radiation, but most types of cancers can be treated with radiation as part of the overall treatment plan.
You mentioned how the chemotherapy can sensitize the cells. Is there timing related to when the chemo should be administered based dependent on when the radiation is administered?
It depends on the chemo being given, and it also depends on what type of cancer we're treating. I use cervical cancer as an example because it is really growing in the numbers worldwide. The numbers keep going up, and hopefully we will change that in the future. But the timing of the radiation and the chemo together is really critical. And we want to make sure that the patients receive the chemo and the radiation in the same week, and that there's not a big delay between starting the chemotherapy and the radiation being delivered, because sometimes there's logistical gaps. We also want to make sure that the patient is still getting the chemo while they're getting the external beam, but not too close to the brachytherapy, because it can drop their counts so much by the end, they may not be a surgical candidate until they get optimized. So you have to be very careful with the timing. Kind of our standard approach for these cervix patients is they start chemo RT in the same week, which is they start their external beam course, they get their first dose of, it's usually cisplatin, and they will get the cycles of those as they progress through the 5 weeks of external beam. And then we will come in towards the end and we will give their doses of brachytherapy. It's usually HDR brachytherapy when it's available. When I say when it's available, because not everybody has access to the brachytherapy, but it is best practice to include the brachytherapy at the end for locally advanced cervical cancer. And our goal will be to get all that chemo, the external beam radiation, as well as the brachytherapy in under 50 days, which is based on the new Embrace 2 protocol that is very important and being rapidly adopted internationally. Per the NCCN guidelines, it's under 56 days. The Embrace 2 is newer data that has come out. So a lot of teams are kind of transitioning to trying to complete all the chemo and the radiation in under 50 days. So 50 to 56 days, depending on which protocol teams are following. The timing is very important.
And then you also mentioned about 5 weeks external beam. How many doses of HDR brachytherapy do they get in general?
It depends on the center. Different brachytherapy teams have different resources. It's about the dose that they get. They need to have a certain dose, but how that is divided up depends on the facility and if they have access to, for example, if they need to give it all in one visit, that patient may need to stay overnight in the hospital and get multiple doses of HDR or multiple hookups to that machine in one applicator placement. And they might be in the hospital for a few days to complete their course of brachytherapy. Some centers don't have access to a hospital. Some don't have access to overnight. So they may have the patients come as an outpatient 2 to 3 to 4 times to get those doses and go home in between with a new applicator insertion each time. So it just depends on the facility. It depends on the resources and the goal is to get all of it done from the end of external beam and all brachytherapy being delivered at the end, have everything under that 50 to 56 day mark, depending on if you're following Embrace 2 or NCCN guidelines.
Before radiation therapy begins, what assessment should the nurses be performing? And are there any specific tools they should be using?
That kind of gets to the core of what we do as radiation nurses. Some of us work primarily in the clinic. I think this very strongly speaks to our clinic nurses, but also to our nurses in the procedural areas. Nursing 101, we need to have a good baseline assessment of our patients before they start, whether it's external beam or brachytherapy or their cancer treatment course in general. What is their medical history? What are their comorbidities? What is their social history? What do these patients' baseline mental health assessments look like? Because most of the time we're treating cancer with radiation. At times we treat benign conditions, but most of these patients have received a cancer diagnosis. They are going to be receiving treatment that will be causing some side effects, and it's going to cause stress for most of them. And a lot of them have a fear of survivorship or of their ability to survive. So we need to know what their baseline is so we can help get them through their cancer treatment journey and out the other end into survivorship. And we can't do that without a good baseline assessment. So making sure we do head to toe in the procedural area, especially we do this, but also before they start external beam, basic respiratory, neuro, skin, just nursing 101. And also if they have comorbidities, let's say they have severe cardiac conditions, or are they severely diabetic with poorly controlled diabetes? That might impact any skin healing if they have skin reactions. So we want to just work with our physicians, with the patients to get a good baseline assessment, ask targeted questions, not forget about mental health, place referrals early if we need to, whether it be to social work or to nutrition, just anywhere that we can help support these patients. And we also want to, of course, in the pelvis, we want to think about reproductive and sexual health assessment. We need to counsel patients. And this, is not always nursing. This is sometimes in conjunction with our physicians. We need to make sure that if they are interested in fertility preservation, if it's an option, are those referrals being placed? And sometimes we can safely wait until fertility is preserved. Sometimes it can be very detrimental to the patient's survival if we wait too long. So that becomes a multidisciplinary conversation. But pregnancy status needs to be confirmed. We want to make sure, of course, that patients are not pregnant before they start treatment whenever possible. Any fertility concerns and counseling needs can be addressed. We want to know baseline sexual function and concerns. For example, in our prostate patients, what is their baseline SHIM score is a tool that we use, the sexual inventory questionnaire, or their IPSS score, the International Prostate Symptom Score. So that way we know where they are before they start treatment, and we can help them through treatment and watch those symptoms afterwards. So there's lots of tools out there that we can customize to our patients. And it definitely is a multidisciplinary approach to how to get patients through. I don't think it's ever just nurses or ever just physicians. I think each team has to decide how to divide these responsibilities, but to make sure that they're actually reaching the patients and being done.
Since radiation techniques for pelvic cancers can vary, let's break them down by type. What are some of the most common acute side effects in brachytherapy?
In brachytherapy itself, the acute side effects are actually very similar to external beam. But with brachytherapy, they can be a little bit more intense because brachytherapy most of the time is invasive. And in the pelvis, it is usually more invasive than, say, a topical skin brachytherapy treatment. And so the side effects from both prostate brachytherapy as well as cervix, which are very similar in how we care for them and the side effects that we see, they usually will be significant the first day or two, and then they should start to gradually get better. So if you can envision these patients receiving interstitial brachytherapy, be it to prostate or be it, an interstitial gynecologic implant for cervical cancer, they have these needles or these straws. It depends on what you call them, but the brachytherapy catheters themselves are invasive. They go through the tissues in the perineum, in the vagina, or up into the prostate. And that causes local inflammation and discomfort and swelling and a little bit of bleeding. So when those come out, they basically have a bunch of puncture wounds that need to seal over, and they do seal over quite quickly, but it's uncomfortable in the tissues. They may have some tenderness in the perineum. They may have a little bit of, for patients with the vagina, they may have some spotting. should not be bleeding a heavy amount, but may have some spotting, may need to wear a sanitary pad, but it should not be soaking more than a pad an hour. For both prostate patients as well as patients that receive gynecologic brachy, they may have temporary urinary side effects like urinary frequency, urgency, some burning with urination, and all of those things usually are most pronounced in the days following brachytherapy and then should get gradually better. These mirror, though, what you see in external beam as well. It's just usually a little bit more intense with the brachytherapy due to the, more invasive nature. But again, they closely mirror what is seen in external beam.
So let's compare that to external beam. What are some other side effects that you might see with external beam, and when do those usually appear, and how long does it take for them to kind of taper off?
In pelvic external beam radiation, the way that, we'll teach our new nurses is think about what organs lie in the radiation field. And anything that lies in that radiation field is likely going to have some potential temporary, hopefully temporary side effects. If you think about the pelvis, the things that live in there are, bladder, urethra, some bowel, rectum, reproductive organs, skin, some lymph nodes, that's what's there. And so all of those things could potentially have associated side effects. So the most common, again, also for external beam is bladder irritation, cystitis. It can be some burning, some frequency, some urgency, and it can often mimic a UTI. We also have to make sure our patients do not have a UTI. Most of the time they don't, but we don't want to miss that. Once UTI has been ruled out, the mucosa in the bladder and the urethra, it has a very high cell turnover rate. And things with a high cellular turnover rate, like mucosal linings, they respond to radiation very quickly. They also heal very quickly, but they start to break down quite quickly during radiation. And you see those side effects usually first, often into maybe the second week of external beam, you'll start to see that side effect. Bladder side effects is probably the number one thing we teach patients on. You also can see some side effects in bowels. It depends where we're targeting. If we're targeting directly into the cervix, patients may have some side effects in their bowels, but it also can be from the effects of combined chemotherapy. Chemotherapy can cause the diarrhea as well, but if they're getting any radiation dose to the intestine or to the bowel, that can also aggravate it. So sometimes it's due to chemo, sometimes it's due to radiation, but bowel side effects, in particular diarrhea, can be quite common in our patients that are also undergoing chemo. And also sometimes you'll see nausea, even though the stomach is usually outside of the radiation field from concurrent chemo. Sometimes our patients undergoing chemo RT to the pelvis will have nausea. And depending on the dose that goes to the skin, you may start to see some skin reactions as well. For example, if we're treating somebody for vulvar cancer, those tumors are usually, if not directly on the skin, just under the skin. And the skin receives a pretty high radiation dose out of necessity to treat what we need to treat. And so those patients may experience significant skin breakdown or skin reaction and require care that we may not see that in a patient we're treating for, say, prostate cancer, because the dose is more targeted internally. When we're looking at how do we educate these patients, we want to make sure we cover the basis of the main things lying in the field of the pelvis, which is bladder, so urinary side effects, bowel side effects, skin care, good skin care, protecting it from the sun, making sure they're wearing cotton underwear, making sure that they're not having a lot of friction in the area, especially if they're starting to get skin reactions, that we see them and we intervene and we treat them. But those are the core side effects that can be seen. And then, of course, working with their medical oncology team or their chemo team to manage the chemotherapy related side effects as well.
So with those side effects, how do the nurses normally assess the symptoms? And are there other standardized tools that they could use?
So we see our patients regularly during their treatment course, whether it's external beam or with the brachytherapy, we're with them almost continuously. We have pretty much an open door policy. Most radiation clinics do, where if the patients are having difficulty during treatment, if they have increasing side effects, they can come and see us anytime. And the nurses are often there at their point of contact. So we will sit down, we will talk to them, we will see how they're feeling. Also, during radiation, it's very common practice to have what's called an on-treatment visit, or OTV, as they're abbreviated in a lot of centers, where we regularly check in with the patient once a week, regardless of how they're feeling. That's the time where they come in during treatment. They meet with the nurses. We go over any educational items that need to be reiterated or introduced. We do side effect management during that time. And sometimes the patients are feeling pretty good and they don't really have any concerns for the nurses, but they'll still see the physician at that time as a touch point just to make sure that everything is going okay, that any concerns are addressed. So that's kind of our standardized approach. We don't really use a tool other than we do our nursing assessment, the standard nursing assessment flow of kind of a quick head to toe, and we do vitals and we check their weight and make sure that they're doing okay. If they are having a lot of diarrhea from concurrent chemotherapy or due to the radiation to the pelvis, we may check their labs, make sure their electrolytes are okay, and intervene as needed. So it really is site dependent, but those on treatment visits are kind of the core touch point throughout the treatment, where once a week it's guaranteed that we will check in with the patient, see how they're doing, and address any concerns at that time.
I remember when I was working in Brad Onc that the team approach was so important there. And we were really tight that therapists were really good at identifying also if the patient needed to be seen, even if the patient didn't think that they needed to be. Let's talk a little bit about preventive and management strategies for these acute side effects, both pharmacologic and non-pharmacologic.
Yes. Is there a particular side effect you want to start with? I would probably, there's several to go over, but I do think cystitis is probably that and the diarrhea that are patients receiving chemo RT. I think those are probably the most problematic. So we can start with cystitis. I think a lot of the prevention actually, we need to give a lot of credit now to our technology that we have, the advancements in radiation treatments, with how precise the treatments have become with the image guided treatments and organ sparing and the expertise of our physicians and our physicists and our dosimetrists. A lot of the prevention occurs in the radiation planning and the targeting that they do and the technology that we have access to now, because that has led to improved side effects because the treatments are more and more precise. That being said, our patients can and will get side effects as well, because in order to treat what we need to treat, some good tissue does need to be dosed as well. But the difference between cancer and healthy tissue is healthy tissue can recover and cancerous tissue cannot. So the side effects most of the time are temporary and treatable. And our job is to try to help make those as minimal as we're able to. So for the bladder, some things that we can teach the patients, and teaching them early is really important. Like even before they start treatment, we try to do the baseline educational assessment and also give them the baseline education to keep their urinary system as comfortable as possible during treatment. We really encourage hydration, because the more hydrated they are, the more diluted their urine will be and the less acidic it will be. As those tissues start to respond to the radiation, they will become, for lack of a better word, a little bit raw. And if you think of something acidic going on something that is raw, it's going to burn. And these patients do get burning. And so by promoting hydration, their urine becomes less acidic. It doesn't burn as much when they do urinate. And I find a lot of patients who are experiencing the urinary side effects, they don't want to drink because they're afraid to urinate. And it actually makes the burning worse because their urine gets ultra concentrated. So promoting hydration with the right things. Water is, of course, the best, but we really just want them to go easy on anything acidic. Limit the coffee if they're having burning. There's not a lot of spicy beverages, but spicy foods. Limit citrus if they're having the burning. Limit the strong berries. Cranberries are excellent for urinary health, but not necessarily during radiation treatment because they make your urine very acidic. So I always tell patients go easy on any berries or citrus or those types of things. And I tell them if they're not having burning, they can eat whatever they want. This is just a tip. If they develop the burning, it can help. And we also, in addition to promoting hydration, watching what they have the intake of with the spiciness or that very acidic pH, we also can prescribe medications like phenazopyridine. It's available actually over the counter now as well, but that can help kind of numb the urinary tract if they are having burning and give them relief. And then, of course, like we said earlier, we don't want to miss a UTI. Most of the time, it's temporary radiation induced irritation, but we also want to make sure that they don't have a UTI. So we should rule that out as well.
I think one of the other side effects that I always think about, and you mentioned this briefly, but what about preventative management for skin irritation or skin breakdown?
Depending on what we're treating in the pelvis, you can expect more or less skin breakdown, but sometimes patients will have a surprising skin reaction that we don't expect. And then others that we think their skin may react, they actually do pretty good. So I think there's a lot of factors that go into skin reactions. I think there's a lot we're still learning about managing skin reactions all over the body. But the things that they can do the most is to really protect the skin in that area before treatment even starts. This is anywhere on the body. Protecting it from the sun, making sure that they are limiting friction in the area, such as from clothing or from underwear rubbing in the wrong way or really restrictive or tight clothing. We want that skin to get air as much as possible, but the big one is protecting it from the sun. And then if they do start to get skin breakdown, it might be just some erythema all the way down to actual breakdown. That's where we want to be seeing them pretty frequently because they may need different interventions as that skin reaction evolves. And if it's just at the point of erythema, we do give them moisturizers. There's a lot of different opinions out there on skin moisturizers for treatment. We just tell them something without alcohol, without fragrance. There's a couple that, are different bases that we recommend, but patients will use what they like and be like, is this okay? Is this okay? And we just check the ingredients, no alcohol, no fragrances. We do have a few that we recommend, but patients will kind of try, but we want them to start using those early and frequently and just to really baby that skin. And then for treating a patient with vulvar cancer and they start getting a very heavy skin reaction, then that may involve some dressings and ointments with silver, different things to manage those more complex skin reactions. And we also just have to encourage patients to, from a holistic standpoint, to if they're diabetic, is their diabetes under control? We had a patient recently actually for skin brachytherapy, and we were going to be treating his lower leg. And the lower legs, occasionally, we treat like a patient on the shin. They at times have some healing issues. We have to watch those lesions particularly closely. And we had a patient recently, his hemoglobin A1C was 14. And we realized how completely out of control his diabetes was. And we made sure that he got that under tighter control with endocrine before we started because we were afraid that he would have wound healing issues that we could not treat. And so we did have the luxury of time. He was able to see his endocrinologist, get that under tighter control. And then we treated him when his hemoglobin A1C was down to a safer level so he would not have wound healing issues. And it went really well. So there's different considerations for skin, not just from the actual skin itself, but from a holistic standpoint.
We've talked a lot about acute side effects. Can you talk a little bit about some of the more chronic or late side effects of radiation to the pelvis?
Yes, I think one of the ones that we really should focus on is the prevention of vaginal stenosis and adhesions. This is something that I think centers are doing a good job educating our patients about this, but I think we can always do a better job. Anybody who has a vagina who receives treatment to the pelvis, it doesn't matter if it's for vaginal cancer or if it's for bowel or rectal, if they have received radiation to the pelvis, they are at risk for vaginal stenosis and adhesions. And this, of course, can be more pronounced in patients who have a higher dose in the vagina or a larger surface volume of the vagina treated. But over time, that tissue, even long after radiation is done, will undergo late changes where they will have continued scar formation and it starts to lose its elasticity and its functionality. And at times it can stick to itself or adhere, causing these adhesions. And this is a side effect that can be prevented in a lot of patients. And it's important to, and it's something that nurses can really help with. And there is different ways to educate patients, and it does vary by institution and team. There's different opinions out there of are dilators the way to go? Are other methods the way to go? My team is like a firm, everybody needs a dilator that has had radiation to the pelvis, that has a vagina, that does not have a contraindication. So we are very adamant about teaching them about vaginal dilators, using it consistently, showing them how to do it. We give them teaching where we have like a sample one that we show them before they go home. We tell them when to start it, which is typically after the temporary irritation has resolved, usually at about a month. And then we want them to be using it on an ongoing basis. And a lot of patients especially, our patients who are not sexually active or who are quite elderly. They're like, oh, I don't need that. And we have to reiterate to them that even if they are not sexually active or don't plan to be, it's not just for that reason. It's to maintain the health of the vagina. It is also to help with future pelvic exams because we need to be doing exams regularly on these patients to confirm that they're doing okay, to check for any signs of reoccurrence. And it can severely limit pelvic exams if they have adhesions and stenosis, and also can be very uncomfortable for the patient. So we try to approach it from different angles, but I think in terms of late side effects, that's a very, very important one that I think we need to continuously remind patients. And it's not a short-term thing. These changes can occur. We want them doing this for months to years, the vaginal stenosis prevention. So that's the main one that comes to mind. There's other late side effects. Sometimes you can see some chronic radiation cystitis in anybody who's had pelvic radiation where it doesn't resolve at that 2-week mark. It goes on and on and on where they have urinary frequency and urgency or nocturia or dysuria or even hematuria. With those patients, we just want to make sure that we are seeing them regularly, that we are making sure they're not having bladder outlet obstruction or something else going on. And it's usually a collaboration with urology and other specialties there.
The other piece I think we do want to address that you alluded to with vaginal stenosis is that we know radiation therapy in the pelvic area can affect sexual health. How can nurses and other healthcare professionals address those side effects?
Sexual health is a really important aspect of survivorship. And I think a lot of people are uncomfortable talking about it. I myself, in my career, I've had to get more comfortable with counseling patients in this as well. There are things that we can do in our department, and then we have to also know when to refer patients to specialties, and it's a combined approach. So, for example, for our patients that have received prostate cancer treatment, whether it's external beam or for brachytherapy, we will see them every 3 months with the routine, the PSA. They do the IPSS questionnaire of how their lower urinary tract symptoms are looking, and we also do the SHIM score, which is the Sexual Health Inventory for Men, where we grade them. They answer questions, it gives them a score, and that kind of helps us see if they're having worsening erectile dysfunction, if it's stable, if it's improved. And we also get these numbers before treatment, so we know what their baseline is. It's important as we look at these, we want to catch changes early. We want to intervene if we can, like if we were to see that they're having some erectile dysfunction or if they're at high risk for it, such as with any prostate cancer treatment, we may proactively put them on something like sildenafil or tadalafil to increase the penile blood flow, and we'll do these questionnaires. But we often will refer them to sexual health, or there's different types of men's health clinics or urology because we want to refer them early and intervene early if we can. So we use the standardized tool to get a number each time. So we have objective data to track each time. This is something that is heavily owned by our APPs on our team. We have a PA and we have a nurse practitioner, and they are the ones who really own this aspect of our follow-ups. And they will be regularly assessing these things in our patients, getting their scores, prescribing them the sildenafil or tadalafil, counseling them, and then referring them out. But it's a really important part of survivorship that I think we all can do more with. And for our patients with vaginas, they also have different sexual function index scores that we can use. And we do the same, usually in collaboration with gyn-onc. We do their follow-ups pretty jointly every 3 months, and we, see how they are doing as well. So there's a lot we can do, but I think early referral to urology or sexual health and regular screening and early discussion of treatment option, and also including the partner in counseling if they have a partner is important as well, so they can be part of this with the patients.
Those are all some really good points. I'm going to switch gears a little bit and go back to brachytherapy. You've been working with the American Brachytherapy Society to promote brachytherapy nurse education. How have you been working to address the educational gaps in this space?
It's been an interesting couple of years. It's actually been 5 years. This year is 5 years since our first efforts, but I could talk about this for 2 hours. So I'll try to say it concisely. But when I joined nursing and brachytherapy in 2012, I came from trauma ICU with a very strong background in nursing, and I was very shocked how quickly I was completely unsure of what I was doing in 2012 because there was no resources for brachytherapy nurses in existence. If you did an internet search, you would not find anything. And I was really surprised by that because coming from the intensive care world, anything you have questions on, you can look it up. You can read as much as you could possibly want on a different topic until you felt like you knew what you were doing. It wasn't like that in brachytherapy. And I approached the American Brachytherapy Society about 6, 7 years ago and just said, I think we can do more because all the education that existed was for physicists and for radiation oncologists. But there's nurses everywhere in brachytherapy without these historic resources. So in 2021, we actually had plans prior to that, but they were derailed by COVID, as I know everyone everywhere had plans derailed by COVID. So in 2021, we finally had our first event. I was the first live nursing symposium in brachytherapy nursing, and we had 125 centers join live from around the world. So we knew we were onto something. And since then, we have gone through a lot of changes, such as creating a nursing liaison to the board position with the ABS, so our voices can be represented and heard. We formed the world's first nursing as well as RTT, or Radiation Therapist Council for Brachytherapy, through the ABS that has regular meetings. And we're also having webinar series and events and symposiums. And that's just with the ABS. Once the news of this started, then worldwide requests started coming in from nonprofits to other medical associations to individual hospitals to individual physicians reaching out saying, we hear that you all are doing this, we need help, or we need help. And it turned into projects now on every continent. I think last year I went to 12 countries alone, just working with different teams, doing different events, building this network and finding local experts who all then can become the experts in their region and teach. So it's still in its early stages, but it's come a tremendous way in the last 5 years. I'm very excited to say, we this month have our first formal nursing track at the ABS National Conference, and we have nurses coming from all over for that. We have a lot of material on the website, but it's bigger than that. It's projects all around the world, reaching every corner of the world now. Brachytherapy nurses have a network, have free resources, and we are developing tools and conversation and events for them, many of them free of charge. So we are changing this, but it has been an amazing ride. We've met some incredible nurses around the world that all of us do the same thing, just a little bit differently, but the conversation has started. We've done formal needs assessments. We're getting data. We've held events. We are on our way to try to develop our regional based recommendations and hopefully someday, with the right amount of research, some best practices in the future. So it's been a real honor, but a real surprise as well, all that has happened in this space.
That is so cool. It's such a message of, if you see something or don't see something, say something and raise your voice, because an individual can make a difference.
It's been a true honor and honestly, probably the greatest joy of my professional career. It has been being able to help. I always wanted to teach and I didn't foresee this, and the severe need was there. I struggled to learn my job as a very capable nurse. And, when I started having to onboard people as my team grew 10 years ago, I didn't have anything to teach them with, and that didn't feel good. That was where it started to bother me, as I wanted to do better for people who were starting out, and I wanted them to be set up to succeed. And while the nurses were short on materials, we also realized the RTTs felt the same way. So we put us together in a group and went to, ABS, and they listened. And we've been working with some other great societies as well as nonprofits. So it's just exploded. I mean, there's so many projects popping up now that anybody who works in brachytherapy, if they are interested to get involved, there's so much opportunity right now. I mean, even, in the farthest places and farthest corners of the world, we have projects going and on-site support being requested. So it's been pretty amazing. I'm excited to see where it goes.
It's a great message. I have just a few more questions for you. How can healthcare professionals evaluate their own hidden or implicit biases and how they may affect how they care for patients receiving pelvic radiation therapy?
I think implicit bias is something we're hearing more about, but it's also something I'm reflecting more about, especially as I've been going internationally and working with different centers, how do you teach people if you only have one perspective? How do you fully know what it's like to be a nurse somewhere, to know what their reality is when you only know your own? I do a lot of reflection on this pretty regularly. And I think that we can reduce the effects of implicit bias by just always increasing our awareness. I try to recognize when are we assuming things versus what is actual fact. And always asking more questions, I think, than speaking. I can speak a lot on a podcast, but when I'm working with these teams around the world, I ask a lot of questions and I try to listen and be quiet because there's so much that we can learn from each other. The diverse perspectives, just both within the United States as well as around the world, the more perspectives that we have and the more diversity we have, the better our practice is going to be. Another tool that's really helpful is I do get objective data for decision making, and I get it from the areas that I'm working with. We do region-based needs assessments with the same questions that we ask everywhere, but we get the data from those nurses in those areas for what they need and what they're specifically asking for. And then we deliver based off that. So that has really helped as well. But yeah, just self-awareness, self-reflection, and asking a lot of questions. And the best part of all of this is I've been one of the drivers of it, but we now have a network of people who are absolute experts in their regions. And there's a lot of great minds now coming together to tackle this, where we will have so much diversity, so many different countries represented, economic backgrounds, and every cultural variation that I think that's helping reduce implicit bias.
I like the awareness piece and the asking questions. I think those are so important. What are some common misconceptions about radiation therapy and pelvic cancers?
I think common misconceptions is that you cannot safely work around radiation. That is something that I have heard a lot. And in certain regions of the world, the nurses actually report that they have been having trouble getting good applicants because nobody wants to work in radiation because they think that you'll get radiated and that it's not safe. And that's something that, we've really tried to make radiation safety a big part of our teaching to show that actually you can safely work around radiation with today's technology. We do proactive things like signage and, we have lead shielding. In my department, we all wear the personal dosimeters to make sure we're not getting exposed. But knock on wood, I've been in radiation for almost 15 years and never had an exposure. You can safely work around radiation, in the vast majority of settings. And I think that's one misconception. I think also too, radiation still is kind of a mystery for some people in the oncology space. I think at a lot of, oncology events, it's very heavily focused on chemo and immunotherapy and all of those things. And there's usually a very small section for radiation. And I'd like that to get more recognition and exposure. And I think we're getting there, especially with all the things ONS have done and now with the incoming radiation oncology certified nurse exam. But I think radiation needs to be seen as the critical treatment that it is, and it is best practice for many types of cancer. You can't treat them standard of care without radiation. A lot of our patients do really, really good. And I think that that's another thing to emphasize too. Yes, some of our patients are treating palliatively, but also a lot of patients are cured by radiation. It's a really neat treatment. Those are some misconceptions I hope we can clear in the future.
Is there anything else about this topic that's not often discussed? I think you've covered most of what I was thinking about, but other things that you wish people knew more about?
My answer 5 years ago would have been different. I think now my answer is how incredible the amount of global disparity there is in cancer care still. I think we know it, but until we see it with our own eyes and start working with people around the world that are treating with machines that, we had in the 1960s in the United States, or they want to treat people, but their government doesn't allow for the radioactive sources to be imported and they're stuck in customs and they have patients that can't get care. There's not even radiation centers in certain countries in Africa that they have to travel to different countries. Just seeing how fortunate we are that those global disparities being really in the forefront of my mind, I think is something that I hope to draw attention to. I know there's a lot of efforts around the world to really just promote global health and cancer care across the world, but any opportunity, for people who have expertise, there are so many places that need mentors or educators or online virtual presenters, or there's many ways that we can actually help and reach people. Doesn't have to be in person, but it also can be. And there's just so many opportunities out there that I didn't even realize until I kind of started the path that I was on my own. So yeah, I hope that in the future, global health is an amazing thing. And I think seeing these oncology disparities is something that I don't think is discussed enough. Nurses can do a lot, and it doesn't take too many of us. We can do a lot, even in a small group, and try to reach nurses in other areas that need our help as much as possible.
What additional education and or resources are available for nurses or for other healthcare professionals on these topics?
I think the best radiation oncology nursing materials, I would say, are available truly through ONS, through now what will be the ROCN exam prep through ONCC. We are building for brachytherapy specifically through the American Brachytherapy Society, as well as Jack Estro, which is our European counterpart. Estro and Astro. Astro is the American Radiation Oncology Association. They have great resources, as well as Estro, or some call it Estro, which is again the European counterpart for both external beam and for brachytherapy. Just really good content. And there's also going to be some coming out for nurses that are particularly interested in gynecologic cancers. The International Gynecologic Cancer Society as well has some really good, they have a nursing certificate course. They have a lot of good material as well. There's a lot of good stuff out there, but I'm very excited for all the nurses in the US that have been waiting for our own certification exam, that it's finally coming. I'm very happy that we're at this point here in the United States to have that exam through ONCC. So thank you to ONS and ONCC for that.
I agree with you 100% on that. Kayla, it's been great talking with you today. Do you have any final comments for us?
I really appreciate the time, and to have a podcast dedicated to radiation side effects. I think it's nursing 101, but it's so important. If we get our patients through treatment and help them with their side effects as well as survivorship, we've fulfilled our role. And then anything we want to do on top of that, there's a ton of opportunity worldwide for external beam and for brachy. For anybody who's interested, there's lots of ways to help people beyond our patients. So
thank you so much for joining us and for all of the work that you've done. And I hope you have a great rest of your day.
Thank you to you all. Have a wonderful day.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.